Okay, so let's grab out those case studies that you guys have. Okay, let me find it. Here we go. All right, Mary and Elmer, that would be on page, and you have page numbers this time, 22. Okay, so let's look through this here. Mary, 28-year-old Mary. Spiral fracture of a right tib fib. Spiral fractures are nasty. That's where they twist. You don't just snap the bone, you twist it. So you get very awful breaks, right? Fractured right clavicle, chest contusion with multiple fractured ribs, sun peaks. And that's where I see spiral fractures. Where? Because they're in their boot, their ski boot. They get a spiral fracture. Family report, she's a second-year tourism student, fairly good health with no health challenges. She's a non-smoker. But family reports, she likes to report party on the weekends just like any university student. So you see she's getting morphine 5 to 10 milligrams, IM sub-Q, Q4 hours. There's lots of other meds she's getting. Okay? So if you can read, and I'm probably reading a little bit faster than you're reading. Morning post-op day 1, you try to get her dangle at the bedside, but she cries out in pain and refuses. She states her pain is unbearable, and she demands some more pain medication. Now you check her MAR, and you see that she's got morphine 5 milligrams sub-Q at 6:30, oral diclofenac, and Tylenol. And she also got Gravel 50 milligrams IV at 07:15 to rule out nausea and emesis. So in order to rule out compartment syndrome, you check her leg and find she's got adequate color, warmth, and sensation. That's one of the things as an orthopedic nurse I'd be checking. If someone's in extreme pain, you don't want them to get compartment syndrome because that's life or limb. They can lose a limb. But they've checked that out and everything's fine. So why would Mary be having such increase? She's had lots of pain medication. Why is she having so much pain? Maybe. Maybe. Except for the Maureen. Okay, maybe. Maybe more so with diclofenac. Maybe not so much with Tylenol, but yeah, that's a possibility. What else? Yeah. Yeah. Throwing it up. She might have actually even thrown it up too, which happens a lot, right? So go and see if your patients had something for nausea, 10 to 1, they threw up their pills. So maybe she only got the morphine. Now the other possibility always to throw out is this is maybe somebody who's got just a brutal fracture. The worse your trauma is, the more painful it is. There's always, I don't want to sound judgmental. I don't want to sound like the judgmental 37-year-old man here, but you'll learn this in nursing. Mary's 28, but the younger they are, there's also a period of regression where, especially if you got like a 19-year-old, 17-year-old, they tend to get, it's a very traumatic experience for you. It might be the first time you've ever been in the hospital. You might be away from all your friends. And so we know with pain, there's always an emotional component to it, right? We know that. Like I remember the guy I had on peds who had his tonsils taken out. 4 days later, his mom was still holding his popsicle for him. So he's 14 years old, and his mom's holding his popsicle, and the dad's got a wet cloth on his forehead because his pain is unbearable. And I'm thinking, buddy, I got 2-year-olds who the next day are singing operas and eating popcorn and stuff, right? Like, so there is a component always. Now, there is a suggestion, somebody said that, the suggestion of binge drinking. So maybe Mary has damaged her liver. Maybe she's damaged her kidney. Maybe what family calls normal weekend partying is serious 3-day binges, right? I look at Vancouver, they had a phone in about ecstasy users. People called in CBC about ecstasy users. A whole bunch of them are professional business people that use it on the weekend, and they go hard, and then Monday is not a great day at work, and everyone knows their best day is not Mondays. They get it out of their system, and then Friday night, it's let's go party again, right? So that's a possibility. So, oh, you got me. It was a drug designed for actually couples therapy. It was actually designed for psychotherapy. It was used initially for positive. Yeah, that's right. And ecstasy now is mixed with a lot of other stuff. There's no such thing as pure ecstasy anymore. So now if she's got binge drinking and she's damaged her liver, you should only give her a maximum of 2 grams of Tylenol, because we could be doing more damage to her Tylenol by giving her Tylenol every 4 hours. All right, let's look at Elmer. Elmer's complex. Oh, Elmer. All right, so we're using pharmacodynamic concepts. Oops, no, that isn't where I want to go. So Elmer, 82 years old, walking his dog. 105 pounds, 5'8" tall. He lived with his wife for 61 years in their ranch-style home until Elmer and Ethel passed away 8 months due to complication of influenza. With his wife, his medication, his bipolar disorder was managed. He's bipolar. But the daughter reports the family's been worried about him since Ethel passed on. She was the main caregiver. She made sure he took his pills. They report he's lost significant weight and is not keeping up appearances since she has passed away. A PharmaNet search reveals he has not renewed his prescription for 5 weeks. That's always a sign somebody's not doing their medication. So he's got an allergy to morphine, bipolar, he's got peripheral vascular disease and hypertension. There's his meds: lithium, furosemide, hydrochloroside, ramipril, acetaminophen, hydromorphone 1 to 2 milligrams, PO Q6 hours. And remember, hydromorphone is quite potent. Okay? He's on bed rest, NPO, pre-op, but you find he's gentle on turns. And he seems quite comfortable. His affect is very flat. He doesn't understand the pain score, but he denies that he's in any pain. Why would that be? He's got a fractured hip. Those are painful. If I fractured one of your hips, you'd be... Okay, yeah, you could look at it that way. So maybe the emerged nurse has topped them up downstairs. He's come up to your floor, and he doesn't have a high albumin level. Okay, so somebody that mentioned. So what else do we know, okay, about elderly people? So you want to look at lifespans.
So kidneys are not working as well?
Yeah, so you can't excrete them out as well. So maybe his drug is lasting, having a longer therapeutic effect in him. Because we didn't talk about what he's already had, but maybe he's already had something. Okay? I've seen elderly patients be very comfortable on incredibly low doses of morphine. And you would think 1 milligram of morphine sub-Q, how would that help anyone with a fracture? 89 seems to work just great. Okay? What else do we know? Okay. Well, did anyone notice his weight? What's his weight? Way low for 5'8". This guy's lost a lot of weight. So it's just weakness and potential malnutrition. He's got less albumin. He's got fewer protein binding sites for the drug. So there's more free drug, which you talked about, floating around. Yeah, aging liver. Yeah, so it has decreased capacity to produce enzymes. There's decreased blood flow to the liver with age, thus slowed metabolism and slowed excretion. Some elderly patients will tell you plain Tylenol, one, they're scared of morphine, but true, I think some patients, plain Tylenol is more than enough to control their pain. A 35-year-old, no way in hell would 4 grams of Tylenol cover a fractured hip pain. But I've seen it with elderly patients, okay? And I care for people that are 99. The oldest lady I've cared for is 108 years old. And the village of Lillooet swears she's 112, but there was no one to take birth records for 3 years in Lillooet. So nobody knows for sure, but they all swear she's 112. What else? Anyone notice the lithium? Guys, kidneys. So maybe the lithium's damaged his kidneys, especially with peripheral vascular disease. What does peripheral vascular disease do to kidneys? Hypertension, peripheral vascular disease are good indicators of any client that they probably have kidney damage if they're older. Okay, so those two combined with lithium, so renal impairment. So that's something we have to think about. If we start pumping more drugs in there, maybe he won't be able to excrete the drugs out anyways. So you could do lower doses. If you knew nothing about particular meds, you can safely include that it's because of its chronic health challenges and weight loss, and that lower doses of meds are needed. But if you start thinking it might be other things too. He's got decreased perfusion to the gut and intestines, so therefore decreased absorption of suppositories. So if you gave that diclofenac suppository, it might have done nothing if he had something like that. Decreased cardiac output with age, so you get decreased distribution of drugs and metabolism and excretion. And guys, I see you right now. You know what I'll do? I'll post the answers to this case study, okay? And now what would you say, what's one other conflict with flat affect? Yeah, Mary? Yeah. Well, that would be classic, but then you have people that are always manic, and then you have people that are always depressed. A lot of people start with bipolar with postpartum depression, with some women, like that's how my wife started. So when you look at this, maybe Elmer is depressed, and so maybe Elmer actually is in pain, but because of his depression and flat affect, I've seen this in some elderly patients where I think, no way, they're either not culturally telling me they're in pain, or they're so depressed that who cares? I've had patients, I've had a severely depressed suicidal patients who will take nothing for pain. Why is that? They don't care. They deserve to be in pain, right? That doesn't matter anymore. And I've seen that, and you know as a nurse that they are in pain. So you have to sort of use your thinking skills with all this stuff, especially with the elderly with pain control. Okay, there is an introductory post test, and I strongly recommend that you take a look at this. Okay, strongly recommend.